button. So letting you all know that the session is recorded and we will be posting it for those who couldn't join at this time on the Oregon POLST website. And it is my great pleasure to have this opportunity to showcase some incredibly exciting things that are happening with the Oregon POLST Registry platform and the really cool things that we're able to do as a result of the upgrade of the platform with regard to the quality information we get out. This would be the 90% Abby Dotson show and the 10% Susan Tolle show, because this is much more about the registry than it is about the POLST program. Next slide. That's you, Abby. There we go. Abby and I do not have any conflicts of interest to disclose, but I think it's really helpful to explain the difference. Two parts of Oregon POLST are funded and run. The Center for Ethics in Healthcare is the administrative home of the Oregon POLST program. It's supported entirely by private philanthropy, and we don't accept gifts from healthcare industry sources. We administer the program, and there's a lot of work in overseeing that by the executive director, Anthony Anteville. The purpose of the program is run all the committees and the Oregon POLST Coalition, disseminate the educational materials, create videos, and revise the Oregon POLST form as needed. We do a lot of the policy work. What Dr. Dotson runs is the Oregon POLST Registry. It is funded by the Oregon Health Authority, and the Oregon Health Authority, through contract with the Department of Emergency Medicine, runs the registry based physically at the Oregon Health and Science University in the Department of Emergency Medicine. And Oregon, please mute yourselves. There's some additional background picking up. So the Oregon POLST Registry is literally funded by taxpayers, the people of Oregon, which is why it's the Oregon POLST Registry. It lives inside the EMS system and is designed to provide for EMS in the field and for emergency medical personnel, as well as others. But the primary reason was to really be able to get POLST out before, for example, someone might be intubated in the field and readily available. Oregon is happy to share what we learn with others. I do not speak for the POLST Paradigm Office. Oregon is not part of the POLST Paradigm. We separated in 2017, and those details are on our history page in the Oregon POLST website for anyone who wants to know more. We are the founding program, and we happily share without charge our innovations as we're doing today. And we are delighted to have innovations to share. Oregon, as the founding POLST program, was the first to develop POLST, and many of the features are used by other states. And Abby is someone who has a doctorate And her doctorate is in microbiology and immunology from the University of Kansas. She is someone with a passion for innovation and specifically process and systems improvement. She is the director of the Oregon POLST Registry. She runs all of the registry overall business office, statewide efforts, security, and assuring access in a time of crisis. She also serves on the Oregon POLST Coalition, and she is the registry's section leader for the National POLST Paradigm, as well as the technology advisor for the National POLST Paradigm. It is my great pleasure to introduce my colleague and very courageous friend, who, if she had ever known how much work it would to build a new platform, she may not have done it, but we are so grateful on the other side. Please proceed, Abby.
Thank you, Susan. Can you hear me okay?
Yes.
Okay, great. Yeah, Susan's completely right. My inexperience in coming into this position led me to be a little more ambitious than I probably should have been, but we are so excited to tell you some of the new innovations we have coming out today. Before I get started, I just want to share with you guys the people who actually make the registry happen. This is the team that does all the day-to-day work. When you call the registry, these are the very accomplished and skilled research assistants that you talk to. And they're the ones that do all the data entry, and they keep the quality of the registry at the utmost highest that we possibly can. So a big thanks to Melissa, Sylvie, Rhea, and Lacey. I just want to give a little bit of a background about Oregon, POLST, and the registry. I think most of you know this, but I think it's worth saying again that POLST in Oregon stands for Portable Orders for Life-Sustaining Treatment, and it's a set of medical resuscitation orders that facilitate appropriate treatment by paramedics and emergency personnel in the event of a medical emergency. We are really excited that Oregon has such a robust registry, that we have such great support for the POLST program, and we have one of the highest volume, fully funded registry in the U.S., and that we've been recognized as a national leader in end-of-life planning and emergent situations. The Oregon POLST Registry, and Susan mentioned this a little bit, but the Oregon POLST Registry is funded through the Oregon Health Authority, and it's in a private-public partnership with OHSU Department of Emergency Medicine, where I work, and that is contracted through us to run the registry and operations. The registry is a secure electronic record database of POLST orders, and we allow for those orders to be relayed to medical professionals if they ever can't find the physical POLST form. And in Oregon, the registry is a backup to the paper form, and it doesn't replace the original form if someone actually has one of those present during an emergency. So I just want to give a background of how the registry works and the kind of the flow of work. And I think most people understand this, but we know that initially the primary care or palliative care physician or healthcare professional fills out a POLST form with a patient who is medically frail or towards the end of life. And then that POLST form gets sent to OPR. That's where my staff and our team validate the orders. We make sure that the POLST form is complete and ready to be entered into the registry, and then we enter that data into our database. At that point, that data is accessible to the emergency call center housed here at OHSU, and they have 24/7 access to POLST information that they can then relay to emergency medical personnel during the time of a crisis. Throughout our history, the Oregon POLST Registry has undergone a number of exciting innovations. As Susan mentioned, the registry was founded in 2009, and about 2015 is when OHSU began our first ePOLST pilot, and that then led to, over the years, eventually 7 healthcare systems using ePOLST forms to submit. Now, 5 of those are bidirectional using the Vinca platform, and then 2 of them have unidirectional submission of ePOLST forms that they've developed the ePOLST in their own medical record system. Also during this time, about 2016 is when the EDDI pilot began, and EDDI stands for the Emergency Department Information Exchange, and it's an HIE run by Collective Medical Technologies, and that allows POLST information to be automatically pushed when a patient is registered in the ED. And currently that system is live in all Oregon EDs with the exception of the VA. And then over the past couple of years, we, here at the registry, we partnered with Beyond Lucid Technologies to develop our new registry platform. And that is what we're going to talk about today, and that's everything from completely rebuilding the inner workings of the registry and our database and how our data is housed and entered, to increasing ways to make POLST accessible for primary care and end users. So our current workflow, and I don't know if a lot of people know this, but the majority of forms that we receive in the registry are still handwritten. About 70% of POLST forms that we get in the registry are handwritten paper forms, and about 30% are ePOLST that are electronically filled out. The paper forms come to us by 2 ways. The majority of the paper forms come to us by fax or by eFax. And then a small set also come to us through secure file transfer protocol. And then all of the ePOLST come to us through SFTP as well. When the registry receives those forms, our team enters that data. For the paper forms, we enter that data manually. We have a good team of reading difficult handwriting sometimes, but they're very skilled at entering the POLST orders into our registry database. For the ePOLST, we have our new platform has OCR, optical character recognition technology, and so those forms get scanned, and then we have our team go through to verify that that information is correct. However, on the other side, to request the POLST form or to get the POLST form information, it's still a pretty manual process. For a primary care clinic or a non-urgent POLST request, usually the process is that the clinic will call us, they'll verify that a patient has a POLST form in the registry, and then they need to fax us proof of care so that we have proof that that person is in, we can share that medical information, and then we fax them back the POLST form. So you can imagine that's a lot of steps to have access to POLST information. On the other side, as I mentioned briefly, that an emergent POLST inquiry will go to the hotline, and those orders are verbally read immediately to emergency personnel, and then a POLST form can be faxed to an ED. Another thing to keep in mind is that after all of this is said and done, still about 15% of our handwritten paper forms come out as not registry ready. That means that they were incomplete for any number of reasons, anywhere from not being able to read the handwriting, not being able to verify the date of signature, incorrect medical order combinations, or maybe we have the same person with a different name spelling in our registry, so we need to verify conflicting information. And if we don't have the sender of that POLST form on file, the clinic that sent it to us, we don't have anyone to reach out to, and that form never gets in the registry. So our main goal and an objective was to not only make the process of getting a POLST form into the registry easier, it was to make the process of retrieving information out of the registry more streamlined. And we all know that right now, accessing POLST information is more critical than ever. I'm sure all of you know the New York Times article that came out in January about filing suit for wrongful life, and it just came out at a time when we were already starting this process, but it just really validated that this technology is needed, and it's needed now. So with the partnering with Beyond Lucid Technology, we developed our healthcare provider portal. This is the first time ever that healthcare providers will have direct access to the OPR database, and we're so excited about that. We are starting with a standalone web portal. Eventually, we will work on electronic healthcare record integration, but for now, we wanted a platform that could be accessed by anyone at any time, and you didn't have to have a big IT budget to, get your patient's forms out of the registry. There are going to be 2 levels of access, and this is the same as it would be for a paper form or an ePOLST, in that there's a read-only access, and that is for anyone involved in a patient's care. Anyone that has access to a patient's medical record will also have access to their POLST forms. Social workers, nurses, and healthcare administrators, to name a few. And then there's going to be the role of the healthcare or the POLST form creator. And that is for anyone who can legally sign a POLST form. That's their MDs, DOs, NPs, PAs, and NDs. And they'll have full database accessibility to search the platform as well as create an ePOLST. And so I'm going to demonstrate, for the first time, I'm really excited about this, I'm going to demonstrate what the healthcare provider portal looks like, and I'm going to annotate the video as we go through it and explain how to use the platform. And we designed it to be simple. Oh, Laura's naturopathic doctor, ND. And so we designed the platform to be simple and easy to use, and I hope that you're excited about this. The registry will be housed at polstreg.com, and upon enrollment, you will get a username and password, and at that time, when you log in for the first time, you'll be prompted to reset your password. When you do log in, you're going to be taken immediately to the search page. This is where anyone, whether you're a healthcare form creator or just a read-only access, will be able to look up a patient's information. So at this point, you can open a POLST form, you can view to make sure the demographics are correct, you have the ability to print, and we recommend giving a patient a copy of the form, and you have the ability to download the document and save it in your electronic healthcare record. Oops. One thing I will say is that to get this information, you'll need 2 pieces of identifying information. One is usually the first and last name combination or last name date of birth combination. I'm going to skip forward through this because I accidentally presented it again. Okay, and the next stage is to demonstrate how to create an ePOLST. For those that can fill out an ePOLST, you'll need to select what clinic you're sending the form from so that we have the ability to contact you if we have a question or need some follow-up. And then you just enter in the demographic information as you would with your patient. The date of birth needs to be entered as date, /month, /year, year. And then we do recommend that you enter an address, and that's so that we can contact the registrant and let them know they've registered and let them know what their POLST number is. And that's also a chance for them to double check any POLST orders. You can either assign attempt resuscitation full treatment or do not attempt full treatment, limited treatment, or comfort measures only. For all ePOLST, there will be a hard stop for attempt comfort and attempt limited. And then section C is also mandatory. You have the ability to fill out the patient's information on the discussed with section, and then if they click yes, they are able to e-sign. You have the ability to opt the patient out if they do not want their information sent to the registry, and then when the provider clicks the yes button, it automatically signs and dates for you. Now the back page optional information is also present, and you're welcome to fill out any contact information, any preparer information, and if you're the primary care provider for that patient, you can also fill that out and indicate that you were the person who signed the form. We do recommend that you review the information, and when you submit, you will have the ability to then print off the ePulse. We recommend printing off the ePulse and giving it to the patient, and this is what the ePulse will look like. And this is from the exact platform, so this is going to be a very streamlined way to send information. And then you can also download this form for your electronic healthcare record. I see a lot of questions coming in. I will answer them probably all later because I got to keep up with my video. I got to talk as fast as my video is. When you're done, you can log out, and as always, you can contact the registry if you have any questions. I know that was really fast, but we will have a similar tutorial out for training in the future. So how to enroll? This part of the process is going to start slow and then build a little bit as we get going. So we're going to have a rolling enrollment. We're going to start by hopefully doing 2 to 3 healthcare systems or clinics per week. What we want to do is, well, first of all, we have a team of 5 people, so I don't have the ability to enroll everyone immediately. So we're going to do as much as we can handle, but we also want to kind of keep track of how it's going as we're releasing kind of this new technology and this new access. With the portal, you can go to our website, oppolstreg.org, and at the top banner, there's this provider portal link, and that will bring you to the enrollment page. Each healthcare facility, and if it's a large facility, can be broken down into departments or sections. We'll need 1 administrator who will enroll the rest of their team. I will personally enroll the administrators, and then they will be in charge of verifying information and enrolling their personnel and verifying access on a regular basis so that we know that the only people that have access to the registry are the people who have, are able to and qualified to see it. This is what the POLST form or the provider portal enrollment form looks like. We're going to need your organization name, your primary contact name, and that's going to be the administrator who will be doing the enrolling of your team, their email and contact phone number, and about how many people they wish to enroll. And this is sent through Smartsheets, so you can request a copy to be sent to you. And I'll just, this just gives me a list, and we'll go in chronological order in order of enrollment to get everyone on board. So we are so excited to release this. We know this is a lot of new technology coming out, and so we kind of want to have a second phase down the line. So the second phase of the provider portal, once we feel like we're up and running and comfortable with how things are going, is the ability for non-signers to create the POLST form. I think that's one of the main feedback items I've heard right now is people want to have a nurse maybe be able to talk to the patient and fill out the form, and then a doctor or a PA come in and sign it. So we're working on that capability. Again, we want to increase the interoperability with electronic healthcare records. That potential is there, just the funding to create that API is not quite there. And then our next step, and I'm really excited about this part too, is we are in the process of developing a very similar type portal for EMS. And that's where you come in, and we need your help. So I've currently sent out this left side survey here. It's for all EMS personnel. I've posted that on Twitter and our website, and that is for EMS to let us know what they need, what's going to be most helpful for them in the field. Do they need a standalone app on their phone? Do they want to integrate it into their EPCR? We know that there's going to be challenges with rural areas, and we know there's going to need to be the ability to connect to the database when Wi-Fi isn't available. And so those are all things we need to consider and keep in mind as we're moving to this next phase of technology development. Additionally, we just want you to know that the call center is still always going to be up and running because there are going to be times when electronic access just isn't going to be feasible. So the hotline will always remain an option. And also, if you are on the maybe clinic side and maybe have some information on the interoperability or integration into the EHR side, we have a second survey running, and this is a collaboration that I'm doing with the Department of Medical Informatics and Clinical Epidemiology here at OHSU. And we want to develop a roadmap for the next 10 years. Where's this technology going? What do we need to make POLST continue to be easily accessed and to be able to inform decisions as needed? So that was a lot of talking, and so I'm going to stop right now. I'm going to turn it back over to Susan, and she's going to talk about some of the quality measures that we are working on right now.
So this is our final of our 6 objectives, and this says what is so super cool about having such an effective statewide registry. A registry where over half of those who die in Oregon each year have a POLST form in the registry. It's an amazing resource, and clearly it was designed to be a repository to assure immediate access for EMS and in a time of crisis. But I can't help but think one of its most powerful features, and certainly one of the most useful for the Oregon POLST program side, is the quality data that comes out of this. This little booklet that you see on the screen, that booklet goes out with every packet. Next page. So when a form is submitted, the address, which we very much want in Oregon, guides the ability to mail a packet back to the patient. It has this little trifold brochure that shows what your orders mean in lay terms, so you can understand what has actually been entered. It also states how your name was spelled, your date of birth, and verifies the actual orders that were written. If for any reason it's a safety measure that encourages contact with the registry if any of this information is inaccurate. It is not common. It's a very small percentage of the forms entered, but we don't want any form to be entered that does not truly reflect the patient's informed wishes, and the form can be voided. It's a safety measure, it's a quality measure, it's a backup system, but it also offers the opportunity for just-in-time education. Someone has completed a POLST form. Did they fully understand it? And do their surrogates, their support people, those in a crisis we will be talking to, understand what it means? And can we facilitate a conversation by sending out educational materials in a packet? And we are sending 35 or 40,000 of these packets out per year, but we are reaching a larger number of people with this educational materials for just in time. You just filled this out. Here's what it says. Is this right? Does it match your wishes? Next slide. Also, the Oregon POLST Registry carefully provides an annual report in great detail. They provide quarterly reports too, but this annual report puts everything together about all of the forms submitted and has great transparency about things like the rate of non-registry ready forms. It shows trends over time. It acknowledges which healthcare discipline is completing forms. It's an amazing resource for change over time and to highlight or spotlight the possibility that an area needs further investigation by our quality team or more education may be needed. Next slide. This is one of the most powerful things about the new platform, from my perspective, in addition to the wonderful work of serving individual patients and families in a crisis. This goes to the largest health systems in Oregon each month. And it says, on average, what is happening in Oregon how many forms were submitted that month. In this case, we're highlighting non-registry ready forms, and we're showing you how many Oregon tends to have, and the percentage, and we're showing you example, because we're not identifying any health system here for confidentiality, and we never share one health system with another. We give you Oregon aggregate data, that your health system and how it compares to the rest of the state with regard to non-registry ready. Now, health systems in Oregon that are on ePOLST, remember Abby said it's about 30% come in ePOLST, and that is Providence, OHSU, Samaritan Health, Legacy, and Newly Kaiser. And those health systems have very few non-registry ready, and they're usually the paper forms they are also submitting, because health systems can submit both, even though they have an ePOLST system. But then working with Dr. Dotson, these health systems are able to figure out exactly what their problem is with their non-registry ready forms and begin to reduce those numbers, because clearly the goal is that everyone who had a careful and thoughtful conversation wants to have a POLST form has it found and honored. Next slide. Another very powerful thing that goes in each of these reports is the rate of CPR. Oregon's biggest problem is the price of success. If a health system and state embrace POLST enthusiastically, then you reach a place where a little is good, a lot is better, and actually that's not true. That having people who are too healthy to have a POLST form, the healthy 65-year-old at Welcome to Medicare, is not serving that patient well when a conversation is, well, of course you want everything done and full code, full treatment is completed, because of course they do want everything done in their current state of health. But that's the default. That would happen anyway. And it may preclude a more thoughtful conversation through an advanced directive process that would serve the patient better long term. So having high rates of yes to CPR and sharing that with an individual health system has led to looks for incentives or other reasons that high numbers in one health system compared to another for yes to CPR. In 2020, the rates varied between 11% and 49% yes to CPR in the health systems we were looking at. So that variability and feeding it back is helping continued quality improvement. We think the registry has invaluable information to share about quality, and we're continuing to figure out how to get even more of that information available. Next slide. And here we had one request in the chat for the 2 website addresses. The Oregon POLST Registry has its own website address, and as I said, operates and is funded separately. And the Oregon POLST program has its own website. So those answer one of the questions. Abby, I'd love to ask a few of the questions in the chat function to you and let you share them with the group. One was asking how EDDI works. Does EDDI fit into this? How does it work? Is this all going to resolve what EDDI is or EDDI does? Does EDDI live on?
That's a great question. I'm actually going to lump 2 questions together because I'm going to address the EDDI question and the Vinca question. So I know Eric has already jumped off, but I will send him the link separately. But so EDDI is it's kind of a pre-hospital notification system, And how that works is when a patient is registered in the ED, there's an automatic query that then provides all sorts of information, allergies, frequent visits, any other problems or issues that might be flagged. And then it also includes a POLST form if that's part of, if that's something that the patient has. So EDI is much larger than just a POLST system. It's an automated pre-hospital notification system. And then, you know, in terms of VINCA, and this is the OPR portal is not at all replacing the VINCA system for those healthcare systems that are using it. In fact, we designed the portal to complement, you know, platforms like that, like VINCA's platform, in that, you know, VINCA operates at a very large kind of systems level, and we really want to be user-friendly with a zero-cost entry. We want, you know, it's not going to be as one-stop shop and as integrated, but it's available to small clinics, to private clinics, to SNFs, to residential care facilities, and it gives them the ability to fill out an e-POLST without having to implement any sort of additional IT technology into their healthcare system and their electronic healthcare record.
And one of the other things that complements the new portal is we are a bilingual system. We do paper, we do e-POLST. We don't see paper going away for quite some time. There are so many smaller programs not integrated at this point. And we intend for quite some time to maintain the capacity to do both. We are aware that there is one substantial disadvantage to the portal, and that is it is a separate logon. That is very different from the e-POLST systems like VINCA that are integrated into EHR and where you can enter from the patient chart. That will make a huge difference, but that integration is substantially expensive and some small clinics lack the funding to do that option at this time, and the portal is a way to provide that kind of access when it is not otherwise financially feasible. Integration would be the gold standard, and would clearly be more efficient and would allow something to be into the record system, sent to the registry, and printed for the patient all at once. That is just not financially possible for some smaller agencies and organizations at this time. There was a question about whether or not this is live now, and you explained a little bit. There seems to be some eagerness online. What exactly does live mean?
Yeah, that's a great question. Yes, this is up and running and live now, and we're really excited. The only rate limiting factor is having a small team and having to manually enroll people. That's why we're using a system of, you know, give us your administrator and you can enroll your team, because I don't have, my team of 5 can't enroll every single user in Oregon. So we are ready to go, and we will start, you know, assigning the administrator access as soon as we can.
So we have an interesting question that the Quality Committee voted on last week, but is not widely known to the world. And that is whether or not the e-POLST systems have hard stops and prevent things like order combinations that are confusing, to use a kind word, such as yes to CPR and limited treatment. And do you want to comment on what the portal is going to do about that, Abby?
Yeah, the portal is going to follow the POLST Quality Committee's guidelines, and our hard stops are going to be attempt resuscitation cannot be done with either limited treatment or comfort measures only. And then the second hard stop is going to be section C, which is the discussed with section, must be filled out. And then obviously the form must be signed so that the signer must click yes that they attest to that conversation. And those are the main, and then the demographic pieces of information that are required are name, date of birth, and that first and last name and date of birth, and that will meet all requirements to get the form in the registry. But you will know if you don't fill out something correctly or if you miss something, you will get a notification saying, oh wait, don't forget to fill out section C.
So just as we're bilingual in paper and electronic, we actually have some standards that are not exactly the same. We are able to put some hard stops on ePOLST systems that are not hard stops on the paper system because we can't keep people from filling it out. It's on their refrigerator. It's in their electronic record system. And to then simply tell the registry not to load something on paper that otherwise is widely available is a source of major confusion. So while many states have said you can't have CPR unlimited treatment, we have not prohibited it. And instead, we've said it doesn't do much good to prohibit it if you can't actually physically prohibit it. And now that we can, all of our ePOLST systems are prohibiting that. We are allowing the prohibition for section C, which is about who did you speak to? And that section cannot be left blank on ePOLST systems in Providence, in Kaiser, and in the portal. We will be speaking with Vinca if Vinca would like to also set that limit, which we would, the POLST Quality Committee supports. So you can set hard stops in ePOLST and improve quality as one more very powerful way to improve quality. And I think it's worth emphasizing again, Abby, if you wouldn't mind, about the Vinca system is staying intact, the Providence system is staying intact, that this portal is an additional option. Can you give a little bit more because people are asking questions?
Yeah, absolutely. So the systems that are currently developed and are already implemented are doing their job. And the Providence ePOLST completion system, the Kaiser ePOLST completion system, and Vinca's ePOLST completion system are all providing a valued service. And so this isn't a replacement. This is just to help give, you know, for lack of a better term, the smaller guys the ability to have the same type of technology. And I really, you know, this will also spread down then to EMS and give them an electronic ability to access POLST forms as well.
And if there is anyone who wishes to unmute themselves and to ask a question, I understand that some people, for example, are calling in, and I have learned that there are some organizations that won't let people use the chat function, which I did not know before. So if you would like to unmute yourself and ask a question and have a bit more of a free-for-all here in our last few minutes together, you're welcome to do that.
I'll stop sharing so that we can all kind of see each other. One thing, Susan, there was a question from Sarah Jo Tomlin about how to, she asked, is it important to do a new full code POLST, full treatment POLST, if someone changes their DNR, or should you just void it? That's a kind of a good question on your side.
It's an excellent question. If you void the POLST form, their care doesn't change. The presumption, the default, is full code, full treatment, unless there are orders otherwise. If the person now wishes to set some sort of limits, of course, they need a new POLST form that states that. But the utility of a full code, full treatment POLST form is very modest. Hospice programs have sometimes requested to have the option so that patients can truly state that when someone might assume they wished less treatment, but they still want to go back to the hospital, that they could clarify that expectation in a context or setting where it might otherwise be presumed to be different. But clearly, Oregon would like to further bend the curve on the percentage of full code, full treatment, which we have been bending substantially since 2017 in a remarkable way that we published in an article in JAGS in March of this year, and came out in print actually in the July issue of JAGS about bending that curve. But there is more work to be done with POLST being filled out as code status orders or as thinking it was somehow needed or required as part of advanced care planning in a wellness visit.
So next, I would like to address some of the questions that have come up from both Kate and Linda. Kate, the initial portal is going to be full. It's going to be both the read-only access for those who are not form fillers, and there will be the ability to fill out an ePOLST. It is all ready to go right now. Once you've submitted a POLST form, your way to revise it is to submit a new one. And then if you have a POLST form that you want to void, at this time, we're still going to have you call the registry, and one of our amazing team members can just void it on the phone immediately. And then Linda wanted to know what the latest version of the POLST acceptable to the registry is. We accept all paper forms after the 2011 version to 2019 version. We accept all of those paper forms. The ePOLST are only 2019 forms. So any electronic POLST form is going to be the most current version.
And to add to that, that means the registry does not accept forms that were written. So there's 4 versions that are accepted: 2011, 2014, 2018, and 2019 of the Oregon POLST form. Before that, we have both the antibiotic and the feeding tube sections. We lack addresses. There are many things that make matches more difficult, and the form has changed so much, and the data about those changes is so substantial that we are no longer entering forms older than 2011.
And I'll address a question or a comment from Deborah. She says she welcomes the change, but wonders how the POLST will reflect that the individual has signed themselves or a representative has done it. And I think I know what you're asking, but in lieu of that physical signature, the patient has the ability to click yes, I've signed, and that will e-sign the document for them, kind of the same as the provider can do. And that's very common in the ePOLST submission, in all of the ePOLST submissions. I know, as we know, Oregon doesn't require a patient or a surrogate signature for the POLST to be valid. And so there are some healthcare systems that have ePOLST that don't even have that as something that's filled out. Some have the ability to e-sign, and then we're going to have the checkbox that says who signed the form if someone did. And I don't know if you have anything that you want to follow up with that, Susan.
You're quite right. We do, however, require a true attestation on the part of the physician or nurse practitioner or PA or ND that this is in line with the patient wishes, and then it's to reflect back on Section C of who did they speak with. We are assuming that this meets the overall goals and standards of care, which is a supplemental note about the conversation in the patient's medical record. That would be standard medical practice for a goals of care conversation and explaining why the background for the orders that are being entered. Well, we're getting lots of thank yous. We're approaching the end of the hour. And I would like to thank Dr. Dotson and congratulate her on surviving, building the new platform, and creating the new portal. There's some hand clapping going on. We need more of that. We need lots of hand clapping for Dr. Dotson. And I want to thank everyone for joining us and for any portions that were missed. Or colleagues who would like to listen to it or know more. And Abby has also put just a short educational version on her website, or soon will, that has the video that just gives the short demo of how to use the new portal. So thank you for joining us. Thank you for caring so deeply about honoring the wishes of those with advanced illness and frailty.
And a big thanks to the OPR team. They did this as well. They were a big part in this new portal.